for the attendees. If you are dialing in via telephone, Google Hangout has muted you. If you need to speak to the group, please press *6 on your phone to unmute and to mute. If you are using the laptop for audio and visual during the meeting, you can control the mute function on the Hangout. We kindly ask that only those who are speaking to the group unmute the device. If you are a board member, please reserve the question until the end of the presentation or may ask in Google Hangout meeting chat. For public comment, if you would like to provide a public comment, the conflict of interest must be on file. Please send an email to medicaidpharmacy@utah.gov. Attendees that are not members of the DURB board, please enter your contact information on the Google Meet chat or email medicaidpharmacy@utah.gov. Please use the chat on the right if needed. Please provide normative feedback after meeting to help us improve our process moving forward. Thank you. And with that, our chair, Dr. Catherine Smith, has informed me ahead of time that she can't join us for our meeting this morning. Therefore, I will conduct the meeting in her absence. The first item on the agenda, can I have the motion to approve for the minutes, please? Thank you, Kuma. Can I have a second?
Second.
Thank you. All in favor?
Aye.
Any opposed? Any abstention?
Aye.
Next item is the P&T update from Ryan.
Good morning. So this month, next week, the Pharmacy and Therapeutics Committee will have our annual update from the accountable care organizations will be presenting to us. And we will also be discussing glucagon and glucagon analogs for emergency treatment of hypoglycemia.
Thank you. So next item, we will have a roxadustat review from the University DRC.
Good morning. Let me get my slides up for you here. Okay, can you see those slides?
Yes.
Okay, great. So today we're reviewing roxadustat for anemia of CKD. This drug is currently under FDA review for the treatment of adults with anemia of CKD. If approved this year, this agent could become the first available among the novel drug class of HIF propyl hydroxylase inhibitors and the first oral agent for augmenting erythropoiesis in CKD. This will be an additional option to the current injectable erythropoiesis stimulating agents, known as ESAs, that have been in use for over the last 3 decades. Roxadustat is a 3 times weekly oral pill. This dosing frequency is similar to epoetin alpha, which is also administered multiple times a week. The longer-acting ESAs, such as darbepoetin and epoetin beta, are administered on a weekly to monthly basis. Anemia of CKD is characterized by low hemoglobin levels. For adults, this typically means a hemoglobin below 13 grams per deciliter in males or below 12 grams per deciliter in females. CKD anemia is associated with increased hospital admissions, cardiovascular complications such as heart failure and death. Hepcidin is a hormone that downregulates iron absorption and iron mobilization from storage sites. It typically becomes elevated during CKD since the impaired kidneys inadequately clear the protein. Ultimately, elevated hepcidin contributes to iron deficiency, which impedes hemoglobin production. Symptomatic anemia negatively impacts quality of life due to significant fatigue, shortness of breath, muscle cramps, cognitive dysfunction, poor appetite, and depression, among other issues. So roxadustat influences the hypoxia-inducible factor system, where it blocks hydroxylation of HIF-alpha by inhibiting HIF propyl hydroxylase. By stabilizing HIF-alpha, HIF goes on to stimulate genetic transcription for erythropoietin and transporters that play a role in iron absorption. Stabilization of HIF-alpha is also thought to indirectly suppress hepcidin, leading to improvement in iron availability. Altogether, these actions help raise serum hemoglobin. There are several roxadustat clinical trials, but just 2 are fully published so far. The study names of the key phase 3 international RCTs are in gray text on this slide. Study populations include both non-dialysis and dialysis-dependent CKD. Included patients had stage 3 to 5 CKD. Patients without ESA therapy at baseline entered studies with a hemoglobin of 10 grams per deciliter or less, or 10.5 grams per deciliter or less for the Dolomites trial. In studies with patients on ESA therapy at baseline, patients had to have a hemoglobin of 12 grams per deciliter or less prior to switching from their injectable ESA to roxadustat. The hemoglobin treatment target during these studies was 10 to 12 grams per deciliter. Rescue therapies included IV iron, blood transfusion, and injectable ESA treatment. The primary endpoint was the mean change from baseline in hemoglobin to week 28 to 52. In patients with non-dialysis dependent CKD, recent meta-analyses have reported that roxadustat outperforms placebo for improving hemoglobin. Pooled analyses of these phase 3 studies also show the ability of roxadustat to lower hepcidin and decrease the risk of blood transfusion or use of IV iron compared to placebo. Findings from individual studies in dialysis-dependent CKD showed that roxadustat outperforms ESA therapy for the primary endpoint of improvement in hemoglobin. However, based on a meta-analysis, the trend favoring roxadustat was not significant. In pooled analyses with 3 of these 4 dialysis-dependent studies, investigators reported significant reduction in hepcidin with roxadustat versus epoetin and lower risk of blood transfusion and lower need for IV iron compared to epoetin. When considering patient exposure years, insomnia and UTI were the only 2 adverse events reported with a difference of greater than 2 events per 100 exposure years between roxadustat compared to placebo. Based on pooled analysis of 3 placebo-controlled RCTs in non-dialysis dependent patients, roxadustat treatment was similar to placebo regarding MACE-related outcomes. For cardiovascular-related endpoints, it is unclear how roxadustat compares to ESA therapy, since data from the Pyrenees study has yet to be incorporated into meta-analyses for MACE outcomes. But based on a pooled analysis from a subset of these studies, roxadustat was either similar or better than epoetin for MACE and MACE plus, respectively. There is also some evidence suggesting that achieving a hemoglobin level above 11 grams per deciliter with roxadustat rather than below 11 may have a protective effect regarding cardiovascular events. So roxadustat could become an alternative treatment option to parenteral ESAs in the treatment of CKD anemia. Parenteral ESAs, including sub-Q, may require a visit to the healthcare facility for administration. So an oral option may be more convenient for those who are not on dialysis or for those on home dialysis. However, the less frequent dosing of certain ESAs may still be preferred by some patients over a 3 times weekly pill, especially for patients that can receive an ESA during their regular dialysis treatments in the clinic. As in the clinical trials, the hemoglobin target range with roxadustat was 10 to 12 grams per deciliter. This target range is similar to that recommended for injectable ESAs per the KDIGO guideline, considering that authors know the target may be tailored to the patient's symptoms. And roxadustat may be favorable in the setting of ESA resistance and inflammation. ESA resistance occurs in about 10 to 20% of patients with CKD anemia. And iron mobilization due to elevated hepcidin and inflammation is thought to contribute to ESA resistance. Several studies have shown efficacy of roxadustat despite inflammation marked by elevated CRP and despite having low iron at baseline. So for prior authorization criteria, you may consider reserving the use of roxadustat to adults with CKD-related anemia who have stage 3 or greater. You might require documentation that the patient's hemoglobin is below a certain threshold, for example, below 12 grams per deciliter prior to initiation of roxadustat, or based on FDA labeling if thresholds are provided in the package insert. You could consider requiring dosing to be within the FDA-approved dosage. And the other point to consider is that the safety and efficacy of concomitant use with an ESA plus roxadustat is unclear at this time. In the published clinical trials, rescue therapy with an ESA was limited to a maximum of 2 rounds of up to 4 weeks per round while on roxadustat. And I'll go ahead and stop there. Thank you very much.
Any questions for the university? Thank you. So the next item will be the roxadustat PA, but prior to that, we have a discussions that is among the team. That is the ICER, the Institute for Clinical and Economic Review, has recently published that the evidence is insufficient to determine that the roxadustat has clinical meaningful difference in health-related quality of life or provide a net health benefit when compared to the ESA dapagliflozin alpha. And with the roxadustat is still being reviewed by the FDA with anticipated decision to be made in July. Therefore, the pricing is not yet available for us to do any cost analysis. We are asking the board opinion in managing these drugs with 3 different possible rounds after the drugs and pricing become available. With the first option, will be having the drug have open access. However, that we are worried that the patient might be using the medication for different indication other than the anemia condition and non-related to CKD. The second option for managing is requiring the CKD diagnosis code on the claim at the POS. And third option is having the prior authorization as being shown right now. Are you able to see it clear?
A little bit small.
Oh, thank you. So there's few criteria on the roxadustat PA to be considered. First is diagnosis of anemia with chronic kidney disease. Second, trial and failure to increase hemoglobin level with the erythropoiesis stimulating agent. third criteria is not used concomitantly with other erythropoiesis stimulating agent, as it has not been studied together and it's not clear if this is safe. And 4 is plan to monitor hemoglobin level and maintain the target between 10 to 12 gram per deciliter. Reauth criteria is updated letter with medical justification or update chart note demonstrating positive clinical response. Initial authorization is up to 6 months, with reauth is up to 1 year. There is a no section that is a placeholder for any black box warning after the package insert is available, if there's any. And that is all for the PA criteria. And again, we are hoping to receive the opinion from the board about the 3 options to manage the roxadustat.
For some reason, it's coming through kind of pixelated. It's hard to see.
Oh, let me try again.
It's still the same. I think it's might be because you're trying to show 2 things at once. When you were just showing the one format, it seemed to work okay.
Okay.
Yeah, that looks better. It's a little small, but otherwise it's readable. Great, thank you.
Do we know if there's a particular concern over what other indications it might be used for apart from CKD?
There was others, the concern was others, it's just an off-label comparing to what is the FDA indicated for anemia for CKD, just regular anemia or cancer-related anemia, HIV-related anemia, or others.
Thank you.
Any other questions or discussion?
This is Michelle. Sorry, I've been in transit, and so I couldn't speak as easily, but I'm just getting into my office now. I guess without the need for any step-through therapy or anything like that, it feels to me like the most reasonable option is number 2, so that we limit it to the FDA indication, but provide access to the drug without having to go through the prior authorization process. But I'll just pitch that out as a place to start the conversation.
Thank you, Dr. Hoffman.
You're welcome.
Yeah, I agree with that. And I mean, for what we can have it, I don't know if you want Dr. Hoffman to have that be a motion. I can second that as a starting point, then we can discuss that action.
Dr. Byrne, that sounds like a good idea. Just, waiting until the label comes out to see what, how the wording from the FDA is and everything like that. It sounds like a prudent place to start.
Let me make sure I'm understanding correctly. You're saying you want a PA to label once the label is released. Am I understanding that correctly? Neil, is that what you were recommending?
I was just, I was looking, I think it was more centered around option 2. Without having the PA, but requiring the diagnosis code at this point. I don't know, would it be better to have a PA until the label's approved? Any thoughts there? And then go with just a diagnosis? Or just start at that point, like Dr. Hoffman had thought?
To clarify, sorry, Neil. To clarify, the prior authorization right now is proposed and it won't be available or posted or implemented until the package insert is available or until the drug is approved or considered to approve until July. The same with the other 2 options, is open access or requiring diagnosis code.
Okay.
So this is Sharon Weinstein. I'm not sure I understand how much other use there is outside of this diagnosis. Are we concerned that there's going to be misuse or inappropriate use, and that's why we're concerned about making sure we have a prior auth with a diagnosis code? Is the intent to try to narrow the use by keeping this to the what we anticipate to be the labeled indication? I mean, I see a lot of patients with end-stage renal disease, but I don't understand what the concern about how this might be misused, I guess.
Thank you, Dr. Winston, for the questions. I think because right now there is not enough evidence that this is providing more benefit than the regular therapy of the ESA. So we are consider of having the prior authorization to require a step-through therapy through the ESA, or to limit the use to what the label indication is for CKD anemia. By requiring the ICD-10 code at the point of sale, or with the PA. If that answers your question, I'm sorry.
Yeah, yes, it does. So it's not so much the usage outside of chronic kidney disease that is the use per se.
Yes.
Yeah, I got it. Thank you.
So I just have one question. If we are going to get some more new data by July, then what's the rush?
Thank you, Kumar. So this is because we anticipate it's going to be a blockbuster medications, as there is a good amount of patients for Medicaid that is CKD that are on dialysis and also non-dialysis. So we anticipate to review this medication. Earlier, this medication was supposed to be considered for approval by the FDA in March, but however, it's just recently got pushed back to July.
And you know, the fact that it's not as beneficial, the way I heard you guys, you know, if it's not as beneficial, if the benefits are not, you know, clear, you know, then perhaps we could wait. I don't know. I mean, what's the point in giving, you know, some medication that we are not quite sure if it's going to help?
Yeah, Kumar, this is Eric. I mean, I think the idea would be, given the uncertainty, given the newness of the product, that we already have existing products that we understand how they work and how well they work. The idea, I guess, in my mind would be that you require a prior authorization specific to the label of the drug. And even though we don't know that now, we can recommend that the prior authorization criteria be specific to how the FDA approves the drug. But I think then the other step that would make sense to me would be to require failure of one of the existing ESA products.
Right.
And there's there's several products on the market today that, ESA products that can be used for, anemia associated with CKD. So, really just two requirements. One, have you tried and failed one of the existing products? And two, does it match the criteria or the label that's been established by the FDA?
Makes sense.
Thank you for that. That seems quite clear. And so now I understand we just got a little bit ahead of ourselves because the FDA pushed their issuance back on the product insert. So we're just ahead of that now, just timing wise.
Yeah, and just so the board understands, excuse my interruption there, but we plan several months in advance what our topics will be for DUR. And when we have an estimated PDUFA date that this will be reviewed by the FDA, we try to, there's a special, the timing of bringing a new drug to DUR so that we can create PA criteria in a timely way, rather than waiting, 3 months or 4 months after the drug is FDA approved. We try to look at the estimated approval dates, and from that, find drugs that we think are of interest to our population that would warrant review and criteria discussion around criteria. And that was where there was a bit of a mismatch here. We're finding many of our drugs actually that we're interested in reviewing for DUR have kind of fallen into this place where FDA is just delayed review, or they're asking for more information, things like that. So that really is the dynamic we're having here. And so we thought we would move forward with having you present this topic today, and we would be able to discuss it, but understand the dilemma we're in with not yet having approval criteria from FDA.
That makes perfect sense, and I think we may, given that FDA has been busy with something known as the pandemic, we may have that going on for a little while yet. So I mean, that really helps to understand the process and kind of where we may find ourselves in that situation again. So if I could just ask that we have the motion restated to what we're discussing right now, I think maybe we could kind of see where we're at with this.
Happy to rescind the motion.
Thank you.
I apologize. Did we just have a motion?
Nope, we've rescinded a motion.
Oh.
I think that others are closer to where we want to be in terms of making a motion with regard to potentially proceeding with the prior authorization with some estimation around what the FDA will be recommending. But in the meantime, using step-through therapy, using a step-through process.
I have a question first. I was just wondering, in the face of a new medication of uncertain benefit versus what we already have available, is there any reason we can't start with a PA, and if the benefits become clear at a later date, then go back to something like just requiring the CKD diagnosis?
Yeah, of course, that's a feasible option. I mean, we can always revisit PAs, modify them, eliminate them. So we can always make changes in the future.
Yeah.
So do we have a motion then to do this PA and see what we all think?
I move that we adopt the PA tailored to meet the authorization criteria.
I'll second that.
All in favor?
Aye.
Thank you. Any opposed? Any abstention? All right, we were moving forward with the prior authorization tailored to the FDA approval and package insert. Thank you. So next item in the agenda is the chorionic gonadotropin prior authorization.
Yeah, let me go ahead and share my screen. And is everyone able to see that, or do I need to make it bigger? All right, thank you. So first, a little bit background. Chorionic gonadotropin is an FDA-approved drug. It's a covered outpatient drug. However, some of the indications are indications that we cannot cover through Medicaid. It's used in fertility treatments, and it's also used off-label for weight loss. We don't cover weight loss products either. And so that's why we're bringing this up is I think we did have this as open coverage, but there are those indications that we can't cover. And so we just want to make sure it's being used appropriately for indications other than fertility and weight loss or other off-label uses. So make this just a little bigger. How's that?
Fine, thank you.
Okay. So in female patients, this drug is only indicated for fertility treatments. And so one of the criteria that we've got listed is limiting it to male patients only. And then all of the diagnoses listed are in the product labeling. We did have some questions internally as we discussed this around the hypogonadism secondary to pituitary deficiency, as this agent is less efficacious for this indication than some of the other options. And, just depending on your perspective, that is a means to spur spermatogenesis and could also be considered fertility treatment, depending on how you're looking at it. So this indication, we had a little question around. The other ones are pretty straightforward. So we wanted to bring it to the board and see what everyone thinks. Does anyone have any questions about the indications that we have listed, or any comments about the hypogonadism?
So I had a quick question on that. So I know that, yes, that could be interpreted or twisted potentially to be used for fertility, which is not something that can be covered. And is there precedent in other PAs for excluding labeled indications because it could potentially fall under?
Mm-hmm. Yeah, I mean, we have had PAs that we do restrict use to a little tighter than label. Again, the whole point is to restrict for female fertility, as that's an indication. Again, it's off-label, and the product labeling specifically says it can't be used for weight loss, but people do use it for that purpose.
Do you have a typo on cryptorchidism? Is there an R in there?
Yes.
Thank you.
Thank you.
Is there any further discussion on this proposed criteria from the board, or can we take a motion to adopt it?
We're an indecisive bunch today.
I'll move we adopt this PA criteria.
I'll second
I'll
that.
second it.
Thank you. All in favor?
Aye.
Any opposed? Any abstention? Thank you. So we will approve this prior authorization criteria at ACE. With that, our next meeting will be Thursday, June 10. And that is the end of our meeting today. Can I have a motion or any other concern question?
Move to adjourn.
Thank you.
Second.
Second.
All in favor?
Aye.
Any opposed?
Aye.
Thank you.
Good
Thank
to
you for
see you all.
coming today.
Thank you.
Aye.
Thank you.